Hi, I'm Dr. Ray DuBois, Director of MUSC Hollings Cancer Center. MUSC got some very exciting news not too long ago. The U.S. News & World Report rankings on children's hospitals came out, and the MUSC Sean Jenkins Children's Hospital was ranked number 31 for children's cancer across the whole country. Dr. Michelle Hudspeth, a pediatric hematologist oncologist, was a big part of that. The Pediatric Oncology group not only does patient care, but they're also doing a lot of important research. So today we're going to talk about children's cancer, what makes children's cancer different from adult cancer, and some of the very exciting research that's going on here at Hollings Cancer Center in pediatric oncology. Michelle, I'm so glad you're here.
Thank you for having me.
So we're really excited about your U.S. News & World Report rating. That was just wonderful. But a lot of that's based on your outcomes, which are fantastic. So can you explain so everybody knows, why it's so important and why we're excited about it?
Absolutely. I really was just so thrilled for our team to see the recognition of our accomplishments. So we were ranked 31 in the country overall, which is just really fantastic. And I think what's really important to realize is when you break that down and just look at rankings on outcomes alone, we were 15th in the entire country, and actually number 1 in the Southeast. And that's really phenomenal because many of the U.S. News & World Report points are based on volumes, and we are a smaller center, so we're not going to achieve the points in that area. So everything we did on this survey was based on quality and outcomes.
Yeah, that's wonderful. And I think, we've heard those outcome numbers, and it's great to get some recognition for that.
Yes.
So as you know, with peds, it's just little people getting the same medicines as big people. But that's not true. And everybody in the public realized it with the COVID vaccines because they had to do trials in kids to make sure that everything was okay. And it's not just, extrapolating that back to adults. And that's the same with cancer care. So clearly treatment of childhood leukemia and brain cancer, they're not necessarily the same as adult. So what's the difference? Where are we going with that? And do you think that actually we'll start testing some of these treatments directly in children to start with?
Well, I certainly hope so. What's fascinating is that you can count on one hand the number of FDA-approved drugs specifically for childhood cancer. And that's really startling information. What we've often learned to do is take treatments that were already available and figure out how to adapt those to children. Now, what's interesting is like you say, so leukemia and brain tumors, well, that happens in children and it happens in adults. But we know there's a lot of very important differences. One, we know the biology, meaning what are the characteristics of the tumor, how does it behave, what are the drivers of the cancer, are vastly different from children. And so the very underpinnings of the cancer is different. The other thing is that we're treating, sometimes we're treating small infants all the way up through teenagers and young adults. And so we have to be very careful in terms of how do we put these treatments together in developing bodies. We want to prepare these children for a lifetime of health and success. And so it's a big push of why it's so important to have funding for childhood cancer. The other thing is there's actually cancers that only happen in children. So neuroblastoma is a very good example of that. And so the funding piece is really critical.
Yeah, and I think people are finally understanding that. I know there's some very exciting research projects underway just to look for specific targets in childhood cancers, which is exciting.
Yes.
So let's put children's cancer in context, and you probably know these numbers better than I do, but there's about a little over 10,000 kids from birth to age 14 who are diagnosed with cancer each year. Yes. It's one of the top causes of death for kids between 5 and 14. But those death rates have plummeted since 1970, and actually pediatric oncology has made a lot more progress on some fronts than adult, for sure. So there's something like almost 500,000 childhood cancer survivors living now, and that's because of research, and that y'all are so research-oriented in this population to try to really understand what's going to work. So let's talk about what research you're doing now, what you're excited about, and what kind of things you may need more support for.
Absolutely. Well, I love, there's a lot of research going on nationally. And as you highlighted, much of our progress in childhood cancer is because years ago, pediatric oncologists banded together and worked together. And that's been to really a major impact on the way that we've improved survival. But I'd really love to highlight what's going on right here, here on the MUSC Charleston campus. So we are fortunate to not only have the Hollings Cancer Center, but also the Darby Children's Research Institute that have a wonderful collaboration. And so we have a terrific researcher, Dr. Jezebel Rodriguez-Blanco.
Oh, God, she's a superstar.
Oh, she's a superstar. And her focus is on brain tumors, specifically medulloblastoma. And she has really identified some key aspects for medulloblastoma. She's identified that there's cancer stem cells. So we think about there's all sorts of types of stem cells, but these are really driving the disease. She's been able to identify, not only is this what contributes to relapse, but she's been able to identify a pathway that is related to that, and there are medications available to block that pathway. And so we are so excited about what that's going to mean for the future for these patients. And she's just been, as you said, she's a superstar. She's been getting grants from NIH, from the V Foundation, and so we're really excited. She's having a great partnership with our clinical pediatric oncologist to try to work on bringing a clinical trial for these patients. You know, it really is just a wonderful time.
Yeah, no, it's very exciting. I know through the Darby's Cancer Research Institute, Dennis is also involved in trying to help recruit some physician scientists, and that's going to be exciting.
Absolutely. We think that the space for sarcoma research is going to really take off and explode, and we're very excited.
Well, and even now there's some overlap between adult cancer research and children's. I mean, Nancy Clarber-Moore is an example. She, she's focused her career on breast cancer, but in the process of that, she identified a target that's also in pediatric osteosarcoma, and she had already made a humanized antibody. So we're real excited that the FDA considers that sort of an orphan drug indication.
Yes.
And I mean, what do you think about the certain advantages of being part of an NCI Hollings Center versus sort of separate?
Absolutely. Well, I think you just highlighted it so well. And I've always said I am so grateful that we have our Sean Jenkins Children's Hospital, but I'm also grateful that we're part of a larger institution. It really benefits our patients, and that's a prime example. So being part of Hollings really allows us to have that interaction with researchers. What are they learning? Well, can we twist that and then apply it to children? How can we work together as a collaborative team? There's also the infrastructure that comes, with being an NCI designated cancer center. So that's everything from our tumor boards. How do we conduct our multidisciplinary tumor boards so that patients are really getting full benefit, as well as our clinical trials. So we're so happy to be working with the clinical trials office here at Hollings Cancer Center, which is really instrumental to making sure that we have these opportunities available for our patients. Because as you say, it's research that cures cancer. Yeah,
and I think it's also an added plus that Dennis sort of directs the Children's Research Institute, but also is integrated into Hollings too, and that brings us together closer.
Absolutely. So. We're really fortunate that really pediatric cancer, we've found a way to work with and harness the very best of MUSC from across campus.
So, Michelle, you do wear a lot of hats around here. You're the medical director of pediatric oncology, as well as the BMT transplant program director for the whole adult and peds program. So I know that you're really excited about your work in transplant, and that's one of your, one of the things that makes you excited about being here. And during your pediatric residency at Hopkins, you obviously got introduced to that. So what drew you to the field, and what are you most excited about with transplant?
Absolutely.
And there's a lot going on right now.
No, there is a lot going on. Well, I would say that I knew I wanted to do pediatrics first. When I made the decision in high school that I wanted to go into medicine, it was pediatrics. And then I was fortunate enough to do a little internship in college at a children's hospital.
Oh, wow.
And was able, spent 1 week with a pediatric oncologist, and then ended up spending the whole summer with him. And I just fell in love. I loved the beauty of being able 1 minute to look in the microscope, understand the disease, break it down to the molecular levels, but then walk into the room and work with the family and have those very deep, lasting relationships. So it was really the intensity and the complexity, both from the medical side and the human side, that really drew me to pediatric oncology. I was fortunate enough at Hopkins as a second-year resident to take care of pediatric transplant patients as a second-year resident, and that was it. I think my love of immunology had been built here at MUSC, where I went to medical school with Dr. Varela, and the immunology piece just took it a whole nother level. You know, if I fell in love with pediatric oncology for the intensity, transplant just takes it another step further. The relationships that we have with our patients and our families, and really just that driving complexity to get the best outcomes is really exciting for the field. So I'm really, really honored to work with the BMT and CAR-T team here at MUSC across pediatrics and adult. You know, despite many challenges in a state that is classified as rural, where 25% of children live in poverty, we've been able to achieve outcomes that are as good or better than anywhere in the country. And that's incredibly meaningful, because we know that the child or even the adult sitting in rural South Carolina isn't going to be able to access treatments out of state. And so how do we provide that cutting edge care here? And that's been incredibly rewarding.
Yeah. So any future goals you want to mention for that? I mean, I know there's a lot going on, a lot of recruitments. And I just heard Dr. Hess give a talk last week.
Yes.
And some of the outcomes in those CAR-T studies are just phenomenal.
No, it really is. I think it's a great testament to the team of how successfully we've rolled out the CAR-T program, and that continues to grow. We are doing something new all the time. We're also excited that we're likely going to have soon a clinical trial using our own MUSC derived CAR-T cells, and that is very exciting. And I think from the pediatric side, we're really excited to continue to expand options to many different types of diseases. We're obviously focused here today on cancer, but in pediatric bone marrow transplant, we treat a lot of diseases. In fact, we can cure sickle cell disease. Yeah. We can cure immune deficiencies and other really life-threatening disorders that children are born with. And so that's an important part of the work we do as well.
Yeah, I just heard, and you probably knew this before I did, but that people with treatment-resistant lupus are responding to CAR-T therapy. And I wouldn't have predicted it, but it's exciting to see what kind of treatments are going to be available.
Yeah, no, I'm excited. And as you know, we have such a strong rheumatology division here at MUSC too. So I think it's going to be interesting to see how do we apply these things and help even more patients.
Another thing we have to always talk about is toxicity. And as you mentioned earlier, children have a long lifespan ahead of them. And some of the things we do now may exert a negative influence later. So what's happening with the long-term effects, and how do you reduce those or consider those more carefully?
No, exactly. It's really a cornerstone of how we have to practice as a pediatric oncologist. So first, I think one of the big movements has been identifying and understanding more about the biology of the cancers and doing what we call risk stratification. So how can we, from the beginning, based on biology markers, based on response to initial treatment, how can we stratify patients? So we want to get ultimately the best chance of cure, but there may be some patients who can do that with less and some that may need more. So it's really personalizing therapy. So that's been one really important part of what we do. But another thing is looking at actual targeted toxicity. So for instance, there's a class of chemotherapy drugs called anthracyclines, and they can be very toxic for the heart. But they're really a cornerstone for certain diseases that we treat. And so we're really happy to be part of a COG AML trial that's looking at using a special drug to protect the heart up front for all these patients. And we're really excited to see what that's going to do in the future.
Yeah, that's great. Michelle, I know you talk to a lot of anxious parents and families because, 1 minute the kid is running around the playground, everything's normal, and the next minute we've got cancer, and what are we going to do about it? So what do you tell families when they're first facing a cancer diagnosis in one of their children? Because I don't know if I can do the job that you do with that.
Yeah, it is definitely, I think, one of the most important things that we do in having that conversation, but also one of the hardest things. I think first, what I tell families is you have a whole team behind you. And as we're able to sit on that wonderful 10th floor of Sean Jenkins Children's Hospital, surrounded by really a healing environment, I can look at those parents and say, we're here. You have an entire team behind you. And that's really my first focus, because what I tell them is I know you're going to remember about 5% of what I say today. And so what I need you to remember, 2 things. 1, we're here with you and we're behind you. We're going to do everything we can to cure your child. And then secondly, this goes into some of the other differences about pediatric cancer. Many adult cancers are what we call lifestyle cancers, perhaps driven by tobacco use or some other thing. Not the case in pediatric cancer, but it's such a terrible thing to think of that people want to understand why did it happen. And so I really address that with parents and make sure they understand. I tell them it's really critical that you understand this isn't because of something you did or because of something you didn't do. It just is.
Yeah.
It's a really hard thing to accept, but really making sure so then they can focus on their child and know that we're behind them 100%.
Yeah, there's a lot of guilt that goes along with it. So I know that you're well loved by your patients and their families because I hear feedback all the time, and you're very passionate about what you do. So what drives you and keeps you motivated? Because there are some tough cases and not everything always turns out the way you hope.
That's right. There are some really tough cases, and I think we consider that tough part of what we do a very sacred part of what we do. We take that very seriously. My perspective is I can't control what causes children to get cancer, but what we can control is the way that they're treated, the way that we talk with families to make that experience as less painful, at least painful as possible. I think what means a lot to me is I'm fortunate enough, so children who unfortunately haven't survived, many of their parents reach out year to year, sometimes even month to month, and say thank you. And that's so meaningful, I think, to know that we were able to help in what is really just a terrible situation. We say we have incredible lows, and then we have incredible highs. And, just last week, I saw a patient in clinic who had a relapse, required a bone marrow transplant, has really had one of the most tumultuous, difficult treatment courses I have ever seen in my career. And she's moving into college this week.
Wow, that's fantastic. When that happens,
and
you've accomplished something.
No, it's wonderful. One morning 6 months ago, a little boy that over 10 years ago, I remember sitting with his parents and telling them how concerned I was. I was really worried that we weren't going to be able to get him in remission. Well, I'm happy to say that chemotherapy and a bone marrow transplant later, he's now working as a patient care tech here at MUSC.
Yeah, that's rewarding.
And on his way to nursing school. And so that's what it's about. That's really what we want for everyone. We want everyone to get their life back.
Yeah, no, you do tremendous work, and we really appreciate it. So thanks for spending some time with us today. We appreciate what you do, and I know your patients do. And I want to thank everybody for joining us today. Childhood cancer can be a very frightening topic. Luckily, we have experts here at the Children's Hospital and Hollings that know how to deal with this and can work with individuals to make sure we have a good outcome and a lot of hope. Thanks, Michelle.
Absolutely. Thank you.
If this is your first time watching, you can go to our multimedia page and watch past episodes of Crosstalk, and make sure you join us next month as well.